Disorders of iron kinetics and heme metabolism. All right, so the cause of iron deficiency anemia can be, multiple reasons why, but the first one could be from inadequate iron intake. This could be from poor dietary iron consumption. This is pretty common in infants, in the elderly, or in malnourished individuals. It could be that there is an increased iron requirement, and this happens in situations where the iron demand exceeds supply, such as during pregnancy or growth spurts in children. It could be that there is an impaired iron absorption that's happening, so there are conditions that affect the gastrointestinal tract, such as celiac disease or after someone has had gastric surgery. It could also come because of chronic blood loss. This is the most common cause in adults. And sources include gastrointestinal bleeding, that could be from an ulcer, a polyp, or even malignancies. Could happen because of heavy menstruation or repeated blood donations. So the pathogenesis is the iron metabolism involves three main compartments. We have the storage iron. This is primarily in ferritin and hemosiderin in the liver, spleen, and bone marrow. We have the transport iron, which is bound to transferrin in the plasma. And then we have functional iron. This is used in hemoglobin synthesis and the erythroid precursors. So the stages of iron deficiency development, we have stage 1. This is the progressive loss of storage iron. So iron stores in the body decrease progressively, but hemoglobin synthesis and red blood cell production still remain normal. We move on to stage 2. This is exhaustion of iron storage pool. So those iron stores are depleted, leading to reduced iron transport to the bone marrow. Erythropoiesis becomes iron limited, which causes mild anemia in this stage. Stage 3 is functional iron depletion, so significant reduction of functional iron available for hemoglobin synthesis. It's characterized by microcytic hypochromic anemia with low serum ferritin, low serum iron, and increased total iron binding capacity, or a TIBC. This is just a chart that shows what we just talked about on the previous slide. So epidemiology and some risk factors for iron deficiency anemia. So the more susceptible populations are going to be your menstruating women, and this is due to regular blood loss, growing children because they have an increased iron requirement for growth, and pregnant women because they have an increased iron demand for fetal development and expanded blood volume during this time. The less susceptible populations are men. They are generally at a lower risk unless other factors are present, and postmenopausal women because the reduced blood loss will lower the risk. Factors increasing risk of iron deficiency, so regular aspirin use can cause gastrointestinal irritation or bleeding. Alcohol consumption may impair iron absorption and contribute to mucosal damage. Elderly individuals are more likely to have chronic blood loss or malabsorption. Some associated conditions that could cause iron deficiency anemia could be hookworm infection and other parasites. This can cause chronic blood loss through the intestinal mucosa. Excessive exercise is also another option of iron deficiency anemia, and this can lead to increased iron loss through hemolysis and sweating. For the laboratory diagnosis, we're going to do some screening tests. So we're going to look at the CBC, or the complete blood count. This is usually the first indication of iron deficiency anemia. Typical abnormalities will include microcytic hyperchromic anemia, so that means they have a low MCV and MCH. They may have possible thrombocytosis, which means they have an elevated platelet count. For the peripheral blood smear, it will show morphological changes like polychromasia, which means an increased immature red blood cell, which reflects the bone marrow response, or poikilocytosis, which is the variation in red blood cell shape, anisocytosis, which is the variation in red blood cell size, and you may also see some hypochromia, which means you have pale red blood cells due to decreased hemoglobin. For diagnostic tests, we can use serum iron. This will measure the circulating iron bound to transferrin, and you're usually going to see this level decreased in iron deficiency anemia. Then we have total iron binding capacity, or a TIBC test. This will reflect the blood's capacity to bind iron with transferrin. This is typically increased in iron deficiency anemia due to upregulation of transferrin production. You can also test for transferrin saturation. This is the ratio of serum iron to TIBC, and it's expressed as a percentage. It will be decreased once again in iron deficiency anemia, usually at less than 15%. For ferritin, we can also test for that, and it will reflect the body iron stores. It is most sensitive in specific tests for iron deficiency. It is usually decreased in iron deficiency anemia. However, it can be normal or even elevated during inflammation or infection since it is an acute phase reactant, so keep that in mind. Reticulocyte hemoglobin content will measure your hemoglobin content in reticulocytes. It's usually decreased in iron deficiency anemia, which will indicate a reduced iron availability for new red blood cell production. Some specialized lab tests that we can do is we can do an evaluation of heme synthesis. So we can look at the free erythrocyte protoporphyrin. This measures the accumulation of protoporphyrin in red blood cells when iron is unavailable for heme synthesis. This is generally increased in iron deficiency anemia, which reflects impaired heme production due to iron deficiency. It's also elevated in lead poisoning, so just make sure you remember that as well. We can also test for soluble transferrin receptors. This reflects the number of transferrin receptors that are shed into the bloodstream, correlating with cellular iron demand. It is usually elevated in iron deficiency as cells increase transferrin receptor expression to capture more iron. This is useful in differentiating iron deficiency anemia from anemia of chronic disease because the soluble transferrin receptor levels typically remain normal or low. For bone marrow evaluation, we would usually do a Prussian blue stain. This is a direct assessment of iron stores within marrow macrophages and erythroid precursors. Usually it's going to be absent or decreased iron stores, and that helps to confirm iron deficiency. This is reserved for complex or unclear cases because it is an invasive procedure. Again, this is just a chart of the diagnostic test and what you would expect to see. Treatment of iron deficiency anemia. Lots of times we will do treatment for the underlying cause. So if it's a hookworm, we're going to treat hookworm infection or other sources of blood loss to stop that ongoing iron depletion. They can also give iron supplementation, such as oral ferrous sulfate. This is usually the first-line treatment due to its effectiveness and low cost. It does require patient compliance, and it does have a common side effect that includes gastrointestinal discomfort. Then we can give parenteral iron. This is used if oral therapy is ineffective, poorly tolerated, or in cases of malabsorption. You can also do a red blood cell transfusion. This is usually reserved for people who have severe anemia or when rapid correction is needed. It is not a long-term solution. It does treat symptoms, but it doesn't actually fix the iron deficiency itself. In response to the treatment, we will run some tests to see if it's working. So the reticulocyte hemoglobin content, which is an early indicator of response, it will increase as iron becomes available for new red blood cell production. The reticulocyte count, the relative and absolute, these are both expected to rise within 7 to 10 days as the bone marrow starts to respond to iron therapy. Hemoglobin levels should also gradually increase. It's usually typically noticeable about 2 to 3 weeks after therapy. The red blood cell indices, so the MCV and MCH, will start to improve as well as the iron stores are starting to be replenished. For the peripheral blood smear, we're going to have improvement in the red blood cell morphology with reduction in hypochromia and anisopoikilocytosis. Anemia of chronic inflammation. So the cause of this is usually underlying conditions such as chronic inflammatory, infectious, or autoimmune diseases. Some examples of those would be like rheumatoid arthritis, chronic infections like tuberculosis, certain malignancies, and chronic kidney disease. So the pathophysiology on this is impaired ferrokinetics, so the dysregulation of iron metabolism despite adequate or increased iron stores. Iron is sequestered within macrophages and storage sites, making it unavailable for erythropoiesis. So the role of hepcidin. Hepcidin is a key regulatory hormone which is produced by the liver during inflammation. It inhibits intestinal iron absorption and blocks iron release from macrophages and hepatocytes by degrading ferroportin, which is the iron export channel. The result is there is a decreased serum iron despite adequate stores, leading to functional iron deficiency. For lactoferrin, lactoferrin is released by activated neutrophils at sites of inflammation. It binds free iron, which reduces its availability to pathogens, but also limits iron for erythropoiesis. So in summary, anemia of chronic inflammation. So iron is present in abundance in storage sites, but it's unavailable to developing erythroblasts, which actually causes anemia despite the body having adequate iron levels. Shortened red blood cell lifespan. So the exact mechanism is unclear, but inflammation is associated with increased production of hemophagocytic macrophages. These macrophages actively phagocytize red blood cells, contributing to a shortened red blood cell lifespan. This further exacerbates anemia beyond impaired iron utilization. For lab diagnosis, we'll look at the degree of anemia. They usually have typically mild to moderate anemia. Hemoglobin and hematocrit levels are reduced. For the classification of anemia, it's generally normocytic and normochromic, but can be microcytic in prolonged disease. For white blood cell and platelet counts, they are usually normal or maybe slightly decreased. It helps to differentiate this from other marrow disorders. For iron studies, they'll generally have a low serum iron, normal to increased ferritin, which can reflect the increased iron stores, and low total iron binding capacity. For the soluble transferrin receptors, you'll usually have normal or low in anemia of the chronic inflammation, which will help distinguish it from iron deficiency anemia, where the soluble transferrin receptors are actually elevated. For bone marrow examination, it shows iron stores present, but with decreased iron availability for erythropoiesis. For reticulocyte hemoglobin content, it will be typically decrease, which indicates a reduced hemoglobin synthesis in developing red blood cells. For treatment of anemia of chronic inflammation, you can do erythropoietin therapy. This can stimulate red blood cell production by promoting erythroid precursor proliferation and differentiation. This is particularly useful when anemia is severe or associated with chronic kidney disease. We also are going to try to treat the underlying condition. So the primary approach is the management of the root cause of inflammation. Is it infection? Is it autoimmune disease? Is it a malignancy? We need to know that so they can try to treat that. We're also going to try to reduce inflammation. That can help to decrease hepcidin levels and improve iron availability and erythropoiesis. There are some new emerging therapies that are coming out, such as anti-hepcidin agents. These are under investigation to block hepcidin's effects, which would then increase iron release from storage and absorption. There is potential to restore iron availability and improve anemia. For sideroblastic anemia, these are caused by interference in the production of protoporphyrin, which is an essential component of heme synthesis. This disruption leads to defective incorporation of iron into heme. For the pathophysiology, this varies depending on the underlying cause, what's causing it. So you can have acquired forms. This is going to be due to toxins, drugs, and nutritional deficiencies like vitamin B6, alcohol, and myelodysplastic syndromes. These are often reversible if the cause is removed. And then we have hereditary forms. These are genetic defects that affect enzymes in the heme biosynthetic pathway, especially the ALAS2, and that is the first enzyme in the pathway. These are usually X-linked. Some general features of sideroblastic anemia. These are characterized by accumulation of iron within mitochondria of erythroid precursor cells in the bone marrow. These are diagnosed by the Prussian blue staining of bone marrow aspirate or biopsy samples. For the Prussian blue stain findings for ring sideroblast, we will see erythroid precursors with iron-laden mitochondria, which are arranged in a ring around the nucleus. Pathogenomic for sideroblastic anemia. For hereditary disorders, you may have genetic defects that affect heme synthesis enzymes. This will present in childhood or even early adulthood. For acquired disorders, this will result from drugs, toxins, nutritional deficiencies, and myelodysplastic syndromes, and these ones are more common in adults. Lead poisoning, acquired lead poisoning. So sources of lead exposure can be different for adults and children. So for adults, these are usually mainly occupational exposure. So if they work in battery manufacturing, painting, or plumbing, they can generally come across this. Children, they usually get exposure from older homes if there's lead-based paint, contaminated drinking water, soil, and dust. The effects of lead poisoning. So in the central nervous system, this is particularly harmful in children, which can cause impaired mental development and cognitive deficits. In the hematologic system, this can cause anemia by interfering with the heme synthesis. And some other symptoms, we have peripheral neuropathy, so wrist and foot drop, abdominal cramping, vomiting, and seizures. For the mechanism, how lead and porphyrin synthesis, so lead actually inhibits the enzymes in heme biosynthesis. This results in accumulation of toxic intermediates and defective heme production, which leads to sideroblastic anemia. As far as the lab side, we will see an elevated free erythrocyte protoporphyrin. We will see basophilic stippling of red blood cells on peripheral smear, and we may see a presence of a ring sideroblast in bone marrow. For treatment, the primary approach is to remove the lead source. And the secondary one would be a chelation therapy in severe cases. So they would be able to, remove the toxin and hopefully get them better. Porphyrias. This is a group of diseases characterized by impaired production of the porphyrin component of heme. It can be caused by a couple different things. So it can be hereditary or acquired, such as from lead poisoning, which actually we just talked about disrupts the heme synthesis. So heme synthesis abnormalities, defects, or inhibition of enzymes involved in the multi-step pathway of heme synthesis cause accumulation of the porphyrin precursors. Some clinical effects, so symptoms vary, but they can include psychosis and neurological manifestations, can also include photosensitivity, so they can have skin blistering and damage upon exposure to sunlight. For a laboratory test, we would do a detection of elevated porphyrins or porphyrin precursors in urine or feces, which will help to confirm the diagnosis. Iron overload. So you can have acquired iron overload, and this can be from blood transfusions. So if they've had transfusion-related hemosiderosis is what it would be called. This would be from frequent transfusions, which can cause iron accumulation because the iron from the transfused red blood cells exceed the normal daily dietary iron intake. This excess iron accumulates in body tissues, leading to iron overload complications. You can also have a hereditary iron overload. This is primarily caused by mutations in the HFE gene, leading to hereditary hemochromatosis. So homozygous hemochromatosis occurs in approximately 0.05% of Northern Europeans, and it results in excessive intestinal absorption of iron and progressive iron accumulation in the organs. And then we have heterozygous hemochromatosis. This is present in about 13% of Northern Europeans and is usually less severe, often asymptomatic carriers or a mild iron overload. For pathogenesis, we can have tissue damage, so excess iron deposits in organs such as the liver, heart, pancreas, and endocrine glands. Iron catalyzes the formation of reactive oxygen species, like free radicals, causing oxidative damage to cells and tissues. This leads to organ dysfunction, such as cirrhosis, cardiomyopathy, diabetes, and endocrine abnormalities. Some factors that can promote iron absorption is ascorbic acid or vitamin C. This enhances iron absorption by reducing ferric iron to the more absorbable ferrous form. Alcohol increases iron absorption and also contributes to liver damage, so exacerbating iron-related toxicity. For laboratory diagnosis, we would do some screening procedures. So we would look at the transferrin saturation. This measures the percentage of transferrin bound to iron elevated in iron overload. Serum ferritin reflects iron storage levels. High ferritin suggests iron overload can be elevated in inflammation too. Liver enzymes, so we may have elevated levels, which could indicate liver damage due to iron deposition. Diagnostic procedures, we can do genetic testing to identify the mutations in the HFE gene or other related genes to help confirm hereditary hemochromatosis. Monitoring therapy, so regular measurement of serum ferritin, hemoglobin, and hematocrit. We'll do those to assess iron levels and anemia status during treatment. For treatment of hereditary hemochromatosis, we would do a phlebotomy or withdrawal of blood. So this patient would have a regular blood removal, which would reduce body iron by stimulating utilization of stored iron to help make new red blood cells. Transfusion-related hemochromatosis, for treatment, we would do iron chelating drugs. So they would use medications, which are actually going to bind excess iron to promote its excretion. This is used when phlebotomy is not feasible.